Morning. Thank you, Anand. My name is Mike Jones. Like he said, I'm going to be speaking about diuretics and acute pulmonary edema. I have no disclosures. I would like to give a little plug for social media. I used to think that I was really savvy on Facebook. I'm told that that's very 2000s. In 2013, it seems like the it thing is Twitter. And I've often been corrected by my residents. It's not twit or twat, it's tweet. So check us out. Treat and Street EM, that's me. You can follow my residents. You can follow this conference. You can keep an eye on the FOAMhead initiative and also see what we're doing up at Jacoby. So in the next 4 minutes, I hope to explain the basic model of what we colloquially refer to as acute pulmonary edema, but more specifically a subset of acute decompensated heart failure. I'd like to tease apart some of the current treatment guidelines and propose an alternate treatment regimen. What I'd also really like to do is give you some data that's basically to send you back to your respective EDs to help you annoy and pester your attendings about why they do what they do, and what the evidence is, and really just think about what we're doing to our patients. So, acute decompensated heart failure. We see this all the time. 6 a.m., EMS notification line rings. They're bringing in a 74-year-old gentleman, woke up acutely short of breath. BP is through the roof, O2 is in the toilet. The nurse tells you basically, it's another 6 a.m. APE. Our clinical approach to acute decompensated heart failure is a reflection of the conceptual model that we choose to apply to this disease. So this is not the patient that's coming in. Our 74-year-old gentleman is drowning, yes, but it's not because he suddenly guzzled 2 liters of water and now it's filling his lungs. There are a lot of studies out there, 2 relatively recent ones. They evaluated the patterns of weight gain and intracardiac pressures in the acutely hospitalized heart failure patient. They measured weight gain as a surrogate for fluid retention and clearly showed that most patients gain either no or minimal weight before hospitalization for acute decompensated heart failure, despite a progressive increase in diastolic filling pressures preceding the exacerbation. So this is really a much better model. We all remember this, Pulp Fiction, Vinny Vega, his shot of adrenaline. All right, so the body experiences some insult, which causes a sympathetic surge. You have epi, norepi, vaso, renin. They're all raging through the body, causing a peripheral clamp down. Basically, the increased afterload leads to elevated ventricular filling pressures, in effect stalling the heart with subsequent backup into the lungs. The fundamental problem here is not volume overload, but rather volume redistribution. In fact, frequently these patients are euvolemic or hypovolemic. So if that's the case, why do we all reach for Lasix in these patients? Why are we so encouraged to make these patients pee? This approach only makes sense if volume overload is accepted as the primary issue. In reality, with the exacerbation, the exception is dialysis-dependent patients. Volume overload is not really the primary problem. It's volume redistribution. Removal of fluid will eventually help via diuresis, and that will improve cardiac performance, but it's an inefficient mechanism to do so, particularly in patients with advanced heart failure, where issues of renal insufficiency and diuretic resistance may complicate the picture. In addition, diuresis may cause harm and worsening of the decompensated state by causing an increased surge in catecholamines. So back to the original question, why do we do this? Why do we diurese our patients? Well, we're told to do so by a handful of expert panels and clinical guidelines, not because there's any clear evidence to do this. In fact, there's actually, the best I can tell, no to minimal evidence that this is effective. Whoops, that's the wrong slide. Sorry, I'm going to skip forward. So I'd like to give you an alternative, nitroglycerin. We know that this is it's a peripheral dilator. Basically what it does is it can reduce the afterload and help the heart pump forward to more appropriately redistribute the misplaced volume for the lungs and also help better perfuse the kidneys, causing a natural and balanced diuresis. So you guys all remember this from med school, 0.4 milligrams sublingual Q5 minutes, all right? So there's a caveat with nitro. You have to give the right dose. So if we do some basic math, we let our clueless third-year med student write this order without batting an eyelash, yet we cringe about starting a nitro drip at a level higher than 20 when we're standing right at the bedside. Yet we let our med students give 80 mics a minute all the time. I encourage you, basically, give the right dose of nitro. Some say start even as high as 400 mics a minute and slowly titrate down. So when the phone rings the next time you're standing in the resuscitation bay waiting, basically you're sitting there, you're waiting, start talking about what the right treatment is for this patient. It really is not Lasix. Back to our own clinical guidelines, there are actually no level A recommendations for the treatment of acute pulmonary edema. Level B guidelines, they're pretty weak. Basically, they recommend diuretics in combination with nitrates. Oops, sorry. Our level C recommendations, this is the one I actually really love, is that aggressive diuretic monotherapy is unlikely to prevent the need for endotracheal intubation compared with aggressive nitrate monotherapy. Nowhere in our clinical guidelines do we mention diuretics on their own. So I encourage you to think about this. Go with nitro, skip the Lasix. All right. Bottom line, don't be pushing on a pull door. Think about what the problem is here. It's volume redistribution, not volume overload, and address that problem. If you have any questions, tweet me.